Welcome to the Morehouse School of Medicine's event, Our Secret Burden, Demystifying Myths, Understanding Treatment Options, and Amplifying the Voices of Fibroid Sufferers. My name is Adriana Hopkins. I work with ABC7 News here in Washington, D.C. I'll be moderating this event for you all tonight. It's a pleasure to be here. Now, this is hopefully the first of many educational and informative sessions highlighting women's health issues and health equity with leading scientists and physicians researching diseases and working toward prevention, treatment, and a cure. Now, we do have several people to thank for tonight's educational program. First, the Morehouse School of Medicine, RCMI, Center for Translational Research and Health Disparities. The center is a long-standing program at Morehouse School of Medicine focused on developing MSM research infrastructure, including human research capability. Now, this cycle, the center is focused on developing multidisciplinary translational teams, bringing biomedical, clinical, and behavioral investigators and others together to focus their combined expertise to address targeted health disparities in minority and underserved populations, translating discoveries into practical health solutions. Also, Myevent Sciences, thank you to them. This company aspires to redefine care through purpose-driven science, empowering medicines and transformative advocacy. They believe the first step to progress is understanding the problem. The diseases they are focused on affect millions of women and men, often in their most productive years, and their team is committed to bringing much-needed attention and innovation to these common conditions. Obziva, thank you for your sponsorship tonight. Obziva is a clinical stage biopharmaceutical company with the skills, experience, and backing to usher in a new era in women's reproductive health. Obziva's purpose is to bring to market the products women need, focusing on the treatment of serious conditions such as uterine fibroids, endometriosis, and preterm labor. In November of last year, Obziva submitted its marketing authorization application to the European Medicines Agency for Linzagolix. That's a treatment of women with uterine fibroids. Obziva does expect to submit a new drug application to the FDA in the first 6 months of this year. And if approved, it would be the only oral medication with flexible dose regimen options for the diverse population of women who do suffer from uterine fibroids. And last but not least, a project near and dear to my heart, the White Dress Project. It is a nonprofit patient advocacy organization founded in 2015. It is dedicated to raising global awareness about the uterine fibroid epidemic through education, research, community, and advocacy. The White Dress Project is committed to this mission by advocating for research funding, highlighting reproductive health inequities, educating many on fibroids and their treatment options, and empowering a community who will advocate for their best health choices and no longer suffer in silence with this chronic illness. And with that, tonight's program begins with our first speaker, Dr. Valerie Montgomery Rice, the president and dean of Morehouse School of Medicine. She is the 6th president of Morehouse School of Medicine and the first woman to lead the freestanding medical institution. She is a renowned infertility specialist and researcher. She provides a valuable combination of experience at the highest levels of patient care and medical research, as well as organizational management and public health policy to the Morehouse School of Medicine. Welcome, Dr. Montgomery.
Thank you. This is really a wonderful time to be a woman and to be experiencing the opportunities that are being put forth for solutions to chronic problems that we've been experiencing for years. So welcome to Morehouse School of Medicine, because this is a time unlike any other we've seen in our lives and in our country. And what we do now will matter for years to come. I apologize for not having on my white today, but this is my Founders Day for Delta Sigma Theta, so I had to wear red. But no, I carry the white dress motto in my heart, because I would not be a reproductive endocrinologist and fertility specialist if it were not for my interest in fibroid disease. The first surgery that I experienced as a reproductive endocrinologist or OBGYN student in training was a myomectomy. And it was that myomectomy that really led me to understand what you could do to really maintain women's opportunity to have children. And I never lost sight of how important giving women those options were. Even amidst a global pandemic where we are suffering the greatest illnesses and loss of life, we must all take time to pause and reflect on the myriad of recent state and national incidents and their implications as we continue to stake our claim to social justice through community engagement, and particularly through innovative research that will advance health equity. And what you're going to talk about today, you all, is so important in advancing health equity. Because when we take away a woman's right to choose whether it is to keep her uterus or not, for childbearing purposes or not, we actually do not give her the opportunity to achieve health equity. And so what you're going to be talking about, learning about the basics of the disease process, but the options for treatment and care are so important. Women across the life course live, lead, and carry the torch for families, communities, businesses, and our nation. And in doing so, women are learning that they must first put their oxygen mask on for their health and wellness. And they must do that first for themselves in order to really care for their families and their community. Now, while many people know that I'm an academic administrator and leader, I spent a large part of my career, you all, in the operating room, doing myomectomies and other type of surgeries that maintained a woman's ability to really have choice. Today's event, Our Secret Burden Sufferers, is extremely important to me because I can tell you countless stories of how women have navigated this maze of the challenges and complications associated with fibroid disease. Each member of this panel represents an important area of research leadership. They are experts in basic science, clinical, social behavior science, legislative and social activists, and most importantly, you all, they are influencers who care about you, by the community, for change. All of these areas, you all, must work together for research that matters. And in turn, we must translate those findings to the community, ensuring that we deliver on the promise of science. When we do that, we call that TX, and you're going to learn more about that today. Today's panelists are in no way strangers meeting for the first time. They have been partners in this for a while, committed to their fields and to the importance of their work towards women's health. We are so excited about the conversation that's being designed today and delivered, dispelling myths and confirming facts on fibroids, helping you to learn your options, helping you to consider ways to elevate your voice. I am excited that in this momentous time of fear, of myth, of social injustice and unrest, that many of us are still focused on something that is critically important, and that is helping women to achieve their best self, to achieve health equity. We will welcome your challenging questions and your thoughts. We want you to participate in the process because you are the greatest agent for your health and for the health of your family. So please raise your voice, be a partner, advocate with us, learn with us, help us to be innovative and creative. And again, thank you for coming to Morehouse School of Medicine, even if virtually, as we began to have this wonderful conversation. Thank you.
Dr. Rice, thank you so much for your words, and thank you for your career and what you've done in advocating on behalf of women and your patients. And I think you hit the nail spot on the head. In these times of fear and social injustice, it's very important that we put women first and that we focus on racial and socioeconomic health equity. So thank you for having me tonight for your event. I'm going to now introduce our panelists and give you a look at their expertise and where they're coming from. So first we have Dr. Winston E. Thompson, a professor and chair of the Department of Physiology and director of the Mentoring Academy program and director of research in the Department of Obstetrics and Gynecology at Morehouse School of Medicine there in Atlanta, Georgia. He received his Bachelor of Arts degree in biology from Lafayette College, a Master of Science degree in endocrinology from Rutgers University, and he received a joint PhD degree in cell biology and developmental biology from Rutgers University and the University of Medicine and Dentistry of New Jersey. Now, Dr. Thompson joined the faculty of the Department of Cell Biology as a postdoctoral fellow at Harvard Medical School, and he also received training as an embryologist at the world-renowned Marine Biological Laboratories. You will hear from him later tonight. Dr. John Lippman is an expert in uterine fibroid embolization. After his training, Dr. Lippman practiced interventional radiology in a large private practice group in Atlanta for 14 years. And then in 2005, he started his own private practice, the Atlanta Fibroid Center. In 2015, he opened a state-of-the-art 5,400 square foot outpatient medical facility, caring for patients throughout the southeastern US, the Caribbean, and as far away as Africa and New Zealand. Now, he is best known for his pioneering work in non-surgical treatment of uterine fibroid, but Dr. Lippman's practice treats a number of different medical conditions, including tubal infertility, migraines, and osteoporotic compression fractures of the spine. Dr. Ayman Al-Hindi is internationally educated. He is currently a professor and vice chair of research in the Department of Obstetrics and Gynecology, the advisor to the Dean of Medicine at the Pritzker School of Medicine at the University of Chicago. He is a gynecologist and endoscopic surgeon at UC Medical Center in Chicago, Illinois, with a very busy practice that focuses on serving women with symptomatic uterine fibroids and premature ovarian insufficiency. In the US, Dr. Al-Hindi held various faculty positions at the University of Texas Medical Branch in Galveston, Meharry Medical College and Vanderbilt University, Nashville, Tennessee, and Medical College of Georgia, Augusta, Georgia, before moving to Chicago, Illinois. Now, his medical research interests focus on developing novel therapies, including gene and stem cell therapy for premature ovarian insufficiency, endometriosis, and particularly uterine fibroids. You will hear from him tonight as well. Tabia Henry Akintobi is a professor of community health and preventive medicine, the associate dean of community engagement, and principal investigator and director of the Prevention Research Center. She received her bachelor's degree from the University of Miami and earned both a master's of public health and doctorate of philosophy in public health from the University of South Florida's College of Public Health. She is the principal investigator of the CDC's funded Morehouse School of Medicine Prevention Research Center. She focuses on addressing health disparities, and her public health leadership is also evident through appointments to national task forces designed to shape the science and practice of effective community-based participatory and translational research and collaborations, bridging the gaps between basic, clinical, and community-based stakeholders to address disparities and advance health equity. She is also regularly invited as a speaker and lecturer and has received several awards for outstanding public health research in leadership and training. And last but not least, we have Tanika Gray Valbrand. She is the founder of the nonprofit, the White Dress Project. Again, a sponsor of tonight's event, a sponsor and a project that focuses on patient advocacy and education of uterine fibroids and women's health issues, as well as bringing research attention to those issues. And back in July, you'll recall that was Fibroid Awareness Month. Tanika and the White Dress Project were a big proponent of making that month a legitimate thing through Congress. So those are your speakers tonight. Right now, we begin with Dr. Winston Thomas, whose focus will be on the basic science foundation of fibroids, the myths and the facts.
Good evening, everyone. Thank you, Ms. Hopkins, for that warm greetings, and I thank everyone for participating in this very impactful event this evening. I hope that you all will learn something new or to reaffirm some truths as it relates to uterine fibroid. We and others have been focusing on this particular question: where do fibroids come from? And hopefully, as I go through this basic science presentation, it will start to give you some clues on the direction that we're taking in our laboratory. So at Morehouse School of Medicine, our vision is to lead in the creation and advancement of health equity. In order for us to achieve this vision, we have to work collaboratively and in partnership as the way to move forward with our partners and friends. We at Morehouse School of Medicine want to make a clear difference in women's health and the health and well-being of their families. We will advance women's health by translating our innovative discoveries to the bedside, to the patient, to the community. In addition to my presentation, this work was sponsored by the National Institute of Health. And through this partnership and sponsorship, I've partnered with Dr. Ayman Al-Hindi, Tabia Akintobi, Ms. Valbrand, Dr. Yang, Dr. Trowdry, and Dr. Driss, as well as Dr. Saswati Banerjee and Ms. Wei Zook. All contributes to the content of this presentation. Our president mentioned earlier about one of our transformative models that we have developed and trademarked at Morehouse School of Medicine that you will hear further about from Dr. Akintobi. So what we're trying to do at Morehouse School of Medicine as it relates to the translational spectrum, and to allow the translational spectrum to be transformative, we have, as you can see in this Venn diagram, that I'm a basic scientist partnering with a clinical scientist, such as Dr. Ayman Al-Hindi and Dr. Littman, partnering with Dr. Akintobi, a behavioral and population scientist, to the community, as well as with policymakers from Ms. Tanika Valbrand to communicating with Congress. All along the spectrum, we would like to engage with our community to inform them and to get feedback from them in terms of the research that we're doing at Morehouse School of Medicine, so that we can address some of the disparities as it relates to our community in a timely fashion. So uterine fibroid. Uterine fibroid is a benign smooth muscle tumor. It's non-cancerous, but it has created great distress in women. It occurs in about 80% of women, and the significant morbidity to this particular disease range from hysterectomy. It causes other gynecological dysfunction, such as heavy bleeding that leads to anemia. The bleeding can be between menses. It also creates great pain and suffering, leads to infertility, premature labor. And as you can see here, the fibroids that are removed from a woman can range from anywhere from 5 centimeters as large as 25 centimeters in size. They are associated with the myometrium, as you can see within, as well as outside and within the uterus as well, which is one of the challenge for us as researchers and physician scientists trying to figure out where do fibroids come from. There are certain risk factors that are associated with uterine fibroid, for example, age, family history of uterine fibroid, no history of pregnancy, high blood pressure, use of soy milk, and vitamin D deficiency. You will hear more about vitamin D deficiency from Dr. Ayman Al-Hindi later on. Another risk factor is just being an African-American woman. 2 to 3 times more likely to get fibroid than our Caucasian counterpart. It occurs in a younger age in African-American women and grows more rapidly with great symptomology. This leads to a higher rate of surgery for African-American women, both myomectomy as well as hysterectomy. So one of the questions that we are continuing to explore in our laboratory, where do uterine fibroids come from? We and others believe that uterine fibroid comes from a group of cells called stem cells. And these stem cells, you can have normal stem cells or genetic deficient stem cell that we believe leads to the progression of tumorigenesis. Because these cells can self-renew, they can create daughter cells that produce smooth muscle cells. These are the cells that makes up the myometrium, as well as fibroblastic cells. These cells can respond to steroid hormones such as progesterone and estrogen. So you can see a mutation that is driving these cells can lead to the effects of uterine fibroid that we believe if we can understand these cells, we can make better treatment options. So we hope that these stem cells, these are adult stem cells that we're using. These are stem cells that we have identified from the myometrial layer. And we have obtained stem cells from normal myometrium as well as the diseased myometrium from the fibroid itself or within the myometrium from a diseased uterus. We have isolated these cells and we can culture these cells. These cells have a specific genetic marker on the surface of the cells, and using antibodies, we can isolate these cells from the tissue. We can dissociate the cells from these tissue, and then we can grow them in the laboratory. We next can isolate the genetic material from these cells, from the normal as well as the disease form. From that, we use a tool called RNA sequencing, where we can look at the RNA population from a normal cell versus a disease cell, and we compare the differences. And from that, we can identify genes that are specifically associated with the disease stem cell population compared to the normal stem population. From that, here's a cartoon of a cell that we have identified some key players that we believe contributes to uterine fibroid. These genetic material can lead to increase in extracellular matrix, which is a hallmark of uterine fibroid, leads to growth of these cells. They can proliferate, as well as it prevent these cells from dying, which we call apoptosis. So now we have a set of genes that we can now explore and try and see if we can figure out what these particular genetic material or gene products is contributing to. In order to do that, we have developed a tool in our laboratory, the use of 3D dimensional models. In this case, we are using a 3D-dimensional model called organoids. And the reason why it's called an organoid is because these are derived from stem cells. So the stem cells, we can use those stem cells to create an organ within a dish. And so it mimics the organ's behavior. And so through that, we believe that this can lead to personalized medicine, where we can isolate stem cell from a patient. We can grow them in culture and create these spherical structure that we can now identify their genetic makeup and try to figure out in terms of what drug is best to lead to the prevention of fibroid or the inhibition of the growth of these fibroids. We can also use genetic editing to see if we edit the genes that are mutated, will that lead to normal development of the fibroid. Also, we can utilize the organoid to look at toxicity of drugs that may be used for treating uterine fibroid. So it's a powerful tool for precision medicine. Just to show you an example of that, we can isolate these stem cells with specific antibodies. In this case, the CD44 STRO1 antibody. But when you grow them in a two-dimensional culture, these cells can differentiate into smooth muscle cells or fibroblastic type cells. When we take these population of cells and we put them in a three-dimensional matrix, these cells can, with time, can develop into the spherical structure that eventually can develop into an organoid. From this organoid, we can use powerful tool to look at the cellular architecture. In this case here, we're using a tool called a Confocal Microscope. And as you can see, the cells that we culture in this three-dimensional matrix, they can orient and find their spatial orientation within this three-dimensional model. As you can see here, we have smooth muscle cells that are oriented on the surface of this organoid. When we optically section through all the way to the bottom, you can see there are very few smooth muscle cells within the structure. We also can stimulate these structure with various hormones, such as the steroid hormone progesterone and estrogen. And we know that these cells respond by the presence of the receptor, in this case, the progesterone receptor and estrogen receptor. So this is a powerful tool that will allow us to now to begin to address where do fibroids come from and whether these genetic mutation that we've identified leads to uterine fibroid development. So along the same line of our research, we also have an important obligation, and that is to communicate and engage with our community. And just to show you an example, I was invited to Congress by David Scott and Senator Elizabeth Warren to attend a Women's Health 2001 State of the Gynecological Health in the United States. As you can see here, this is Congressman David Scott, and my wife, Gina, was with me. And during that opportunity of presenting at the briefing, I also met Miss Tanika Valbrand, very dynamic and phenomenal woman, a woman that's advocating for her disease. As you can see from the panel, we have various organizations that were present at that meeting. She gave me an opportunity to move around Congress with her team, and it was an eye-opener for me as a basic scientist to meet the various congresspersons and advocating for more funding for uterine fibroids. So I learned a lot from that engagement and how policies work. So that's part of our TX model. In addition to that, we have an obligation to train the next generation of researchers. From our sponsored program, our research sponsored program from NIH, we have also high school students as well as students from our neighborhood college, such as from Spelman College, Morehouse College, and Clark Atlanta University, that we are training so that they can become the next leaders in this space. And as you can see from this slide, we have engaged with over 500 community learners and leaders in this space. So my last note is that without reproduction, there's no life. Thank you.
Dr. Thompson, thank you so much for your presentation. We do have a couple of questions that I'm hoping you can answer for our guests tonight. Two of them are regarding diet. And you mentioned that we're still researching and trying to figure out what causes fibroids. One of the questions is there a diet that is beneficial for reducing the size of or the symptoms of fibroids? And there is so much conflicting information regarding that in terms of red meat, soy, other products, and sugar. The other question relating to the diet is, once a woman has had her fibroids removed, is there any change in diet that should happen to prevent those fibroids from returning?
So I will defer that question to Dr. Ayman El-Hindi, and I would encourage the person that asked that question to stay on. I think he will provide some informative question that he can address that particular question there as it relates to diet and some of the innovative approaches that we're looking at as it relates to diet and reducing of uterine fibroid.
Now we have several questions regarding infertility and the proper treatment as well. Would those be questions that you want to answer, or defer those as well?
I will defer that to the clinicians. Thank you.
All right, Dr. Thompson. Okay, up next we have Dr. Lippman. He will be discussing uterine fibroid embolization. That is a treatment for women who have fibroids.
Well, thanks very much. I want to thank Dr. Montgomery Rice and Dr. Thompson for the invitation to participate in this outstanding panel. I have nothing to disclose. Every day in my office, I see fibroid patients and I'm constantly demystifying myths. So I was really excited to join this panel because that's what I deal with every single day at the Atlanta Fibroid Center. And some of the most common ones I've listed here. Women should just deal with heavy periods. That's some women are just heavy bleeders. In fact, sometimes they'll say, yeah, I'm a heavy bleeder. My mom was a heavy bleeder. That's just kind of our lot in life. That's a myth. That's wrong. Bleeding heavily is normal if it's been going on a long time. Another myth, despite blood gushing out or flooding out or passing these large clots, if you're not significantly anemic, the doctor doesn't need to treat you. And I've heard physicians say, well, we checked her hemoglobin, it was okay, despite these horrific quality of life changes that need to be treated. Symptomatic fibroids, once the medical options are no longer effective, there are only surgical choices, either myomectomy or hysterectomy. That's a myth. And I'm going to talk about an outstanding procedure that we've been doing here at the center for 25 years, yet most people have never heard about it, called UFE. And once women have completed childbearing, they don't need their uterus anymore. Again, another myth. Sometimes women don't realize what heavy is. If you're changing pads more frequently than every 3 hours, or you're changing more than one pad at a time, or more than 8 in a day, or if you have to sit on newsprint, or you can't sleep with your good linens because you're afraid of bleeding or accidents, obviously this is way too heavy. If you got episodes of blood, as I mentioned, of blood gushing out or flooding or clots or accidents in blood, this is not normal. when you bleed to that extent, oftentimes you get what's called anemia, a deficit of iron and hemoglobin. And when you lose more than you can replace, you get the clinical signs of anemia, which are as follows: being tired and weak, which is usually worse around the period. You might get lightheaded or dizzy or brain fog, just not your sharpest thinking. You may get palpitations, your heart races because it has less circulating red cells, it has to work harder. You might chew or crave ice. That's a very common thing. And when I ask patients about it, they think I'm clairvoyant. How did you know? They may eat things that are not edible, like chalk or Georgia white clay or dirt. Those are also common. It's a sign of chronic anemia, migraine-like headaches, thinning of the hair, brittle hair, hair loss. The hair loss for those patients that are anemic is reversible, unlike mine, which is permanent. And they're relieved to hear that. These fibroids are hard and firm. They're like rocks. And sometimes the patients can feel them if they're in the front of the uterus, and they cause bulk-related symptoms. They cause pain and pressure. They press on the pelvic nerves to cause pelvic pain, or it can radiate into the back and down the legs, called sciatica. And that can be confusing because a lot of docs, if a woman presents with sciatica, they think the problem is in the spine or from lifting heavy objects, and they don't realize it's the fibroids that are pressing on these nerves to cause the same kind of pain. If they press on the bladder, they cause increased urinary frequency and waking up at night. The pressure may be so severe that sometimes they leak urine, or they press on the colon to cause constipation, and again, mislead doctors to think there's a GI problem. It's a mechanical fibroid problem. Or if they press on the cervix to cause painful intercourse. Well, there are a number of treatment options. Medical is usually done first, whether it's non-steroidal anti-inflammatories like ibuprofen, or a specific one called tranexamic acid. There's hormonal treatments and some of these newer agents, but it's a talk in and of itself. Obviously, there are surgical treatments, but I want to focus on this one that's completely non-surgical called UFE. Well, UFE has been available for over 25 years, yet the vast majority of people that suffer with fibroids have never heard of it. In 2000, well, it started in the mid to 1990s, 1994, 95, when we did the first one in Georgia here in Atlanta. But we've been doing this for years, and yet it took quite a while, not till 2008, till the American College of OBGYN finally gave it stamp of approval, giving it the highest level of scientific evidence, which is level A, saying that this UFE procedure is good based on the medical research, not only in short-term trials, but in long-term. We have 10, 20, 25-year data now. Back in 2013, the chairman of OBGYN at the Mayo Clinic, Elizabeth Stewart, published a study in looking at over roughly 1,000 women that were suffering with fibroids. And they were surprised to find out that the average time to treatment for these women suffering with fibroids was over 3.5 years, and a quarter of them waited over 5 years. And they didn't understand, well, why are they waiting? Well, when they drilled down and actually looked at the data, most of these women wanted to keep their uterus. They didn't want to lose their uterus with hysterectomy. And in fact, a lot of them didn't want surgery of any kind, but they weren't given a non-surgical option like UFE. More recently, a Harris poll looked at over 1,000 women. Most of them had never heard of UFE. Even the fibroid sufferers hadn't heard of UFE. Those that did know, most of them did not hear about UFE from their OBGYN. And some women believed that hysterectomy was their only option. Well, hysterectomy has been around a long time. We have the highest hysterectomy rate worldwide, and the Southeast has the highest. If you cut the US in quarters, it has the highest rate of hysterectomy. It's the second most common surgery in the United States, which is kind of surprising because half the population doesn't even have a uterus. And the most common reason why we do this is for benign fibroids. Why? Cancer, it's absolutely appropriate, uterine cancer, but as Dr. Thompson mentioned, these tumors are benign. It costs all of us a lot of money to work on hysterectomy, over $9 billion. If you look at lost wages and disability and time away from work, some say 17 billion. The average age of hysterectomy in this country is less than 40. And unfortunately, I see women in their 20s, less than 30, that have already had a hysterectomy. And a woman I saw in the office today, 18 years old, was told that she had to have a hysterectomy for her fibroids. The uterus is not the appendix. Removing it has consequences, and sometimes physicians underappreciate the value of the uterus. It's important for women psychologically. It's important for them sexually. There's a lot of bone loss after hysterectomy, and now there's good evidence to suggest there's cardiovascular effects. Well, the procedure I was mentioning, UFE, is an outpatient one, no surgery. It's a 30 to 40 minute procedure. There's a brief recovery. Either the approach is either from the left wrist or the top of the right leg. Both uterine arteries are blocked to the blood supply to these fibroids. Each uterine artery is like a tree and it branches. The fibroids are the leaves of the tree. So I know what size those tiny peripheral branches are, and we can plug them up as we direct a little tiny catheter the size of a piece of spaghetti into each uterine artery one at a time and deliver agents to block those tiny blood vessels. Without a blood supply, those fibroids will die, and as they die, they soften and shrink, and as that occurs, a woman's symptoms go away. She's discharged the same day, say after a 4-hour recovery, with just a Band-Aid and her uterus. There's a brief recovery at home of about 5 days typically, and we see patients in the office at 3 months. Hopefully, all their symptoms are gone and all the fibroids are dead, because if so, I'll never see them again. It's a very highly successful procedure. 90% or so get the relief they're looking for. There's a very low complication rate, much lower and much less impressive than the surgical complications. And they get what I call the triple crown, typically. 1, they get the relief of symptoms they're looking for. That's really important. 2, they avoid the risks and long recovery of an operation, and they get to keep their uterus, which again, I think is underappreciated. This is actual pictures from a UFE. There's a catheter, very tiny microcatheter, as I say, like a piece of spaghetti in the right uterine artery here. And we've injected contrast that we can see on X-ray. And you can kind of see that there are these circular ball-like figures. Each of these are individual fibroids, and the blood supply is at the edge of each fibroid. And we can plug up those vessels. And you can see over here, those vessels are gone after the embolization on this side. And then we'll repeat the same thing on the other side. These are side view pictures from an MRI. This is the before picture. So both of these women, this is on the left-hand side, the front of her, and this is the back. So we're looking at her like a profile. You can see a bladder here in white, the pubic bone, and then this is the uterus here. And within the uterus, you can see this large black circle. That's the fibroid, which is stretching the lining of her uterus, causing these horrific periods. And 3 months later, you barely see this fibroid, and obviously all of her symptoms are gone. Here's another impressive picture, a very large fibroid at the top of her uterus, and you can barely see where it is just 3 months later. The advantages are obvious. It treats all the fibroids, whether you have 1 or 100, it doesn't matter where they are or how big, how many. It's very effective, it's minimally invasive, it's typically a one-time procedure, it's much safer, it's less invasive, shorter recovery than surgery. There's no surgical wound, there's no general anesthesia, there's no hospital, there's no blood loss. You can treat patients that they can't do surgically or won't do because they don't accept blood products. This procedure is covered by all insurances, and again, you get to keep your uterus. Disadvantages, the fibroids are still there, but they're not causing any symptoms, and that's okay. Most women with fibroids, we call them passengers, have these fibroids their whole life, and they die with these fibroids. They don't cause any symptoms, they don't need any treatment. We're just converting these fibroids that are causing symptoms into dead passengers that don't bother the woman anymore. Occasionally, the fibroids might not be completely dead, and it could require retreatment. That's very unusual. This is performed under X-ray, so there's a very small X-ray dose, which is very acceptable and like getting a CAT scan or a mammogram or other radiographic procedure. Some women don't menstruate permanently after UFE. In the 9,000 I've done over the past 25 years, that's never happened in women under 40. As you get above 40, you'll start to see it very rarely. Even 40 to 45 is 1 to 2%. There are a small percentage of patients, 5%, will temporarily pass some fibroid material vaginally, and very rarely will need a D&C from our gynecologic colleagues to help us deliver some of those fibroids out. On the horizon, which our new vice president, it's very exciting. I hope this legislation passes. She introduced in the Senate, and her colleague in the House, Representative Clark, introduced the Uterine Fibroid Research and Education Act, and Tanika and her colleagues were very involved in this as well. It's going to increase research, which is phenomenal. So Dr. Thompson and others that are on the cutting edge of research will get hopefully the funding they need from the NIH. We'll also educate the public through the CDC, and we'll educate doctors to know all about all these treatments, to disseminate this information because it's so critical. In conclusion, if periods are interfering with your quality of life, that's not normal. Women with fibroids, symptomatic fibroids, they're entitled to know all their options, not just the surgical ones. UFE is outstanding. It has a long 25-year track record of safety and efficacy. Every patient that's considering surgery should at least know about UFE, and not informing patients adds to the general mistrust in all women, but this is obviously a particularly sensitive area for African American women given their history. Thank you.
Dr. Lippman, thank you so much for that presentation. And let me just say personally, if you were the first doctor I saw regarding my fibroids, I wouldn't have gone crazy for so long. It is clear that you listen to your patients and you understand them and you believe them and you advocate for them. And there's so many women out there that I've met through the White Dress Project who that is their first hurdle, getting a doctor to believe that their quality of life is so terrible because of these fibroids that they need treatment, and that treatment is not always a hysterectomy. So I just really appreciate your passion about this.
I appreciate you saying that, and we've done a number of events with Tanika. She's phenomenal. She advocates. We were together at the Georgia State Capitol when she got Georgia to make July Fibroid Awareness Month. It is so important. I wish it were national. She's a powerhouse, and we love working together. And I'm glad there's somebody out there that can do that stuff, because I don't have time to advocate politically. So I'm glad we've got people like Tanika and others.
Yes, you are treating the fibroids, and we appreciate you for that. Now, you do have several questions, and I want to let all the panelists know that you can get into the Q&A section right now and you can answer the questions directly because we don't have time to get to all of them. But Dr. Lippman, you have a lot of questions directed your way. The first is UFE possible and safe following pelvic radiotherapy for cervical cancer treatment? This particular person is on hormone replacement therapy. They do not have any periods, but these fibroids are in fact affecting her quality of life.
If the fibroids are, the simple answer is if the fibroids are affecting your quality of life, yes, you should look into the possibility of UFE. I mean, presuming that the other situation is taken care of, yes, you can.
Is there a risk of early menopause with UFE?
Well, that's what I said during the talk. A very small percentage of patients will not menstruate ever again, an early menopause, but I've never seen that, nor has it been published. There's been a number of trials looking at ovarian function, and none of the premature menopauses occurred in women less than 40. As you get above 40, you start to see it, but it's still very unusual until you get to women that are 50 and over, and usually those women are thrilled at the prospect of not menstruating again.
Now we have two questions regarding UFE and pedunculated fibroids. Is UFE an appropriate treatment for those types of fibroids?
Totally fine. Most of the pedunculated fibroids, in fact, aren't pedunculated. Pedunculated means a narrow, like a lollipop, a narrow stem and then a big ball for the fibroid. Most of them have a broad base of attachment to the uterus, and the unsuspecting radiologist reading the film calls anything away from the uterus pedunculated, and it gets people all excited because there was one case report of a detached fibroid from a pedunculated fibroid. Most are not pedunculated, and even if they were, it doesn't stop us from embolizing them. That has just not been an issue. It's one of these urban myths. So I'm glad you asked that.
Okay, last question for you, and then I'll encourage you to get into the Q&A and answer these remaining questions directed your way. This person is asking, what is the pregnancy and birth success rate in your clinic after UFE?
It's about 60% of patients that want children will have children, which is actually quite good given the fact that our patients are typically older, usually in their mid-30s, late 30s, or early 40s trying for pregnancy. And obviously their age affects their fertility. It makes it lower than a younger population. And our births are typically full term and vaginal. If you have myomectomy, you're going to get a C-section. That's just another surgery. So, and I've had numerous children born after UFE. I've had multiple sets of twins born. So yes, it's a longer discussion. You can't simply say you can. I hear a lot of patients say, well, my doctor told me I can't have UFE because I'm interested in fertility. A myth. It's a longer discussion. I'm not saying everyone should have UFE or everyone should have myomectomy. You've got to go and talk to someone who's experienced in this and really look and find out what your particular scenario is. How many fibroids? How big? Have you ever had surgery before? How old are you? There's a lot of factors, but yes, the simple answer is we've had a lot of children after UFE.
Right. Adriana, I mean, yeah, I agree with Dr. Libman. This is a bigger discussion. There are several aspects. So I hope we'll have a chance in the panel discussion at the end to cover all the aspects of this. It's not a simple, direct answer.
Dr. Al-Hindi, we certainly will. And I'm glad you jumped in because you, sir, are up next discussing the basic science foundation on fibroids, dispelling the myths from the facts. Take it away.
So thank you very much. And I'd like to thank and congratulate Morehouse School of Medicine really on putting this important session together. The title of my talk, I guess there are a couple of titles, but I'm planning to talk about treatment of uterine fibroid, the options and the evidence. These are my disclosures, and I like to particularly thank the NIH for supporting our fibroid research program for the last 18 years or so. So the objective of my talk, after some introductory remarks, I want to touch a little bit on why are uterine fibroids more common in women of color, and then probably entirely focus on medical treatment of uterine fibroid for most of my time, and then finish with some concluding remarks. So Dr. Libman and Dr. Thompson covered very nicely the clinical scenarios, the symptoms and signs of the disease. So I'm not going to repeat that. And also Dr. Thompson covered a little bit of the risk factors of fibroid, but this is such an important topic, like who developed fibroid. The other thing about this is actually kind of a good entry point, try to understand the biology of the disease and try to develop some kind of a research agenda. So as we heard, race and ethnicity, women of color have about 3 to 4 times increased risk of developing fibroid compared to white women. We had in the last 10, 15 years have better understanding why that is the case, but I would still say that we don't have full understanding yet of this process. Vitamin D deficiency. So we were the first group to publish or connect low level of vitamin D in the serum, in the blood, with increased risk of fibroid, almost 11 years ago now. And then since then, this has been confirmed all around the world. The reason this is exciting or important, because it right away start to give some explanation for the first item of why fibroid is more common in women of color, because we get most of our vitamin D from the sun. It's not easy to get enough vitamin D from any diet. So individuals with darker skin, they don't utilize the ultraviolet rays from the sun as effectively, and then they end up being much more common to suffer from vitamin D deficiency. So vitamin D deficiency as a risk factor for fibroid right away start to present some explanation why fibroids are more common in African American and Hispanic American women compared to European American women. Our group and others published on certain genetic factors, genetic markers that might also be associated with increased risk of fibroid, especially those involved in estrogen signaling and estrogen metabolism. Overweight, obesity would increase your risk of fibroid. Interestingly, in the preclinical model that we're using, losing weight actually decrease your risk of fibroid and can shrink pre-existing fibroid. We don't have a lot of data in human on that. Low parity. Those who have not been pregnant or have been pregnant only once or so would be at increased risk of fibroid. Those who had several pregnancy tends to have less risk for fibroid, and even if they develop fibroid, they tend to be much smaller. Early age at menarche. The earlier you have your first period, the higher the risk of you developing fibroid later in life. Family history of fibroid, we're all very familiar with this, very common in our patient. The patient would say, my older sister, my mom also had fibroids. It's very common, which again, connect to some of the genetic factors that I mentioned earlier. Probably the most recent interesting risk factor is adolescent persistent menorrhagia. Most of the patients who have fibroid, and as we heard, you would have heavy menstrual bleeding. When you talk to them, they tell you that my period was actually heavier than my friends and so on, even when I was in the teen years, even before I actually have any evidence of fibroid. So persistent heavy menstrual bleeding in the teen years and early 20s, it suggests that most likely you will develop fibroid later on. And interestingly, some of the molecular data that we have developed recently start to give some explanation for that. So how do we treat fibroid? What are the treatment options? Again, Dr. Libman covered this a little bit, but I want to cover this in kind of in a different point of view. Surgery is still by far the mainstay. We do a lot of surgery for fibroid. Hysterectomy is by far the most common. We do about 600,000 hysterectomies every year in the US alone. Most of them are because of fibroid. We do about 30,000 myomectomies every year in the US. And then some of the more recent procedures such as radiofrequency ablation, ASESA, and so on is also being developed. Radiological interventions such as uterine artery embolization or UFE, we heard a lot about it from Dr. Libman. Another procedure also done by our radiological colleagues is MRI-guided focused ultrasound. But then the medical treatment of fibroid, this is really an exciting area that has been growing, and there's some new development in that area. And that's what I want to bring your attention to, because my main goal always with my fibroid patient is for them to know all their options. I'm a gynecologist, I'm a surgeon, but I would like to give my patients all the options and find the best option in her individual case. So there's some new development in the medical area, and I feel generally that the field is actually heading in that direction. And when I say medical, I mean something you can take by prescription, you use it in the comfort of your home, just like any other medical disease. This kind of support what Dr. Libman talked about earlier, a hysterectomy. This was from a New York Times article saying that maybe we're doing too many hysterectomies. Hysterectomy is indeed the second most frequently performed major operation after cesarean section, and maybe we're doing too many. And he's absolutely right. US is #1 in the developed countries, at least. We do about 5.4 hysterectomy for each 1,000 women. This is almost double what Germany does, and Canada does even just like a small fraction of that. So in the developed countries, we are definitely #1. We're doing, in my opinion, doing too many hysterectomies. So what is the medical treatment? What are the medical treatment options for fibroid? And you can divide those in many different ways. For the sake of this presentation, I divided them into natural therapy and synthetic therapy. Natural therapy, as you can tell, stuff that's not modified, exists in nature, and we use it as is. Synthetic is some chemically developed medication. I'm going to start with the natural therapy. All right, vitamin D. So as I mentioned, we get most of our vitamin D from the sun. It works in the skin, release some of the precursor of vitamin D, and then the inactive form, and then it goes to the kidney and generate the active form of vitamin D that goes and do all the good things that vitamin D does. It's very hard to get enough vitamin D from the diet. So most of the vitamin D we have in our body comes from the sun. And that's why individuals with darker skin will tend to have more risk of developing vitamin D deficiency. So we did this study in 2010, 11 years ago now, and we compared women who have fibroid to women who don't have fibroid. And this is based on ultrasound finding, not just on the patient history or what they think they have fibroid. This is ultrasound confirmed fibroid. And consistently, we found that women who had fibroid have low level of the vitamin D in their blood, both the inactive form and the active form. And that's particularly when we compare them to their equivalent. So, for example, in the African American, we compared women with fibroid and the control, all African American, and still the women with fibroid had much lower level, significantly lower level of serum vitamin D compared to healthy control. The same actually goes for the European American patient as well. Those with fibroid have lower level of vitamin D in their serum compared to healthy control. But if you look at these numbers here on the y-axis, generally European American had higher level of vitamin D in general, but consistently women with fibroid had lower level. The fact that African American in general have lower serum level of vitamin D start to suggest that could be a contributing factor why this disease is more common in women of color. So since our first publication in 2010, this has been confirmed all around the world for more than 45 papers so far from every continent. So this is a global phenomenon. So vitamin D deficiency is definitely a well-established risk factor now for uterine fibroid. And we have published extensively on how does vitamin D actually works as an anti-fibroid agent and why the deficiency would make sense to increase the risk of fibroid. So I would encourage those who are interested to read more about this from our publication. Of course, with this kind of observation, right away, the intuitive question, well, can we use vitamin D then to shrink fibroid, to treat fibroid, or to prevent fibroid? So I haven't been able to do this study yet. We actually have a proposal under review now, so hopefully we'll be able to do this in the US, but other groups in other countries did a smaller studies answering this question. This is a study from Italy in 2016 and from Iran 2019, actually showing that that's actually the case. So vitamin D, if you correct vitamin D deficiency in a fibroid patient, you are able to shrink existing fibroid and also slow the growth of existing fibroid as well. So I'm going to move now to another natural compound, green tea extract. So we did a study several years ago on fibroid patient using a specific extract of green tea. It's called EGCG. We did this because of a lot of preclinical data in the lab and an animal experiment, and then that led eventually to the human study. So we had women with fibroid randomized into one arm getting 800 milligram of EGCG, that's the active ingredients in the green tea, compared to placebo, and we followed them for 6 months, and they got the green tea as capsules, not as liquid and so on, because I get this question a lot. And then we answered the question at the end, how did this woman do as far as the shrinkage of the fibroid and symptoms? And as you can see here, and this work, of course, is published several years ago now, as you can see here, the group that had the green tea, and they are colored green here, they enjoyed about 33% shrinkage in their fibroid, compared to the group that had the placebo actually had about 20% increase in the size of their fibroid. So that we had very good results with this compound. When we looked at the symptom severity using a validated questionnaire, again, we saw that the group that had the green tea extract had significantly less symptom severity at the end of the 6-month study compared to those that had the placebo. And then when we looked at the quality of life using the same questionnaire, the group that had the green tea had much improved quality of life, about 20 points increase in their score, suggesting that their quality of life is much better than before the treatment, while the placebo group had no change in their quality. So, and this is just an example of the ultrasound of one of the patients in our study before the EGCG, the green tea treatment, and you can see the fibroid clearly here in ultrasound and basically it's gone at the end of the study. So now this study was in women with symptomatic uterine fibroid. Now we have an ongoing study funded by the NIH to look at women who have infertility and uterine fibroid. And we are treating them with EGCG versus placebo and other standard treatment. And we're looking if the EGCG would be able to help women with fibroid and infertility achieve a healthy pregnancy and a healthy baby. So this is an ongoing study. If you are interested in getting more information, please check on clinicaltrials.gov and you can search with my name. All right, so that covers briefly the natural therapy, and again, we published extensively on that. So I would encourage you to look this up if you're interested to get more information. Now, on the synthetic side, as we heard from Dr. Libman, some of these options has been around for some time. He kind of covered that briefly, and I'm not also going to spend a lot of time on that because none of these items in black here has been FDA approved or developed specifically for fibroid. Just gynecologists and others have been kind of improvising to help our patient decrease their bleeding, etc., while kind of trying to avoid surgery, which is kind of inevitable in those cases. However, there are 3 new medications, the one in red at the bottom here, that has come about in the last few years and have been developed specifically and being evaluated specifically for treatment of fibroid. And one of them has achieved FDA approval, as I will mention in a second, and the others are on the way. So I'm particularly excited about those because they have been developed and evaluated specifically for the treatment of fibroid. So this group of compounds is called Gnrh receptor antagonist. I know it's a mouthful, but it's basically gonadotropin releasing hormone receptor antagonist. So the way all of these 3 medications, and they work in a very similar fashion, they work on this gland in the brain, it's called the pituitary gland, to block the secretion of certain hormones. Eventually what they do is decrease the release of the estrogen and progesterone from the ovary of the patient. And as we heard from Dr. Thompson earlier, estrogen and progesterone are the lifeline of the fibroid. Fibroid thrive on estrogen and progesterone. And if we can deprive them from estrogen and progesterone, they will just start to shrink and die off. And that's the mechanism of action of all of these 3 compounds. So here's the 3 compounds, and the names are a bit kind of tongue twisters: elagolix, olagolix, and linzagolix. And these are some of the characteristics of each medication. I just want to say that all of these medications are being evaluated for treatment of fibroid in well-designed phase 3 studies, which is the highest level of evidence, as Dr. Libman said. And they're all being evaluated with the add-back therapy. So when you get the medication, you get the active ingredients, one of those, but you also get a little bit of estrogen and progesterone in the same formulation, in the same capsule or tablet, to avoid any of the side effects of the low estrogen level. Elagolix with the add-back therapy has already achieved FDA approval about 6 months ago. It's available under the name of Orion. And olagolix with add-back therapy and linzagolix with add-back therapy is being under evaluation now, and hopefully expected to be approved in the near future. So I'm just going to show you, for the sake of time, just a glimpse of the data from the clinical trials of these 3 compounds. So the study with elagolix and add-back therapy, we published this in the New England Journal early last year, 2020. So I would encourage you to look for the detailed data there. But here in this figure, it's kind of a summary of the main outcome. So here's the timeline in months from the beginning of the study to 1 full year. And here's the amount of menstrual blood loss in women with uterine fibroid. And as you can see here, the group that were randomized to the placebo treatment, unfortunately, continued to bleed very heavily, on average about 250 to 300 ml. But we had really some very, very heavy bleeders in the study. This is just the average. While the group that got elagolix in this case, and the add-back therapy, they enjoyed very quick, major, significant decrease in the blood loss. So right away in the next cycle after starting the treatment, you see about more than 50% reduction in bleeding. And then this goes to more than 86% starting from the second month. And as long as you stay on the medication, you basically bleed very, very little. So that was very encouraging result. The other very encouraging result with this medication is it works on all kinds of fibroid. As I saw from the question that you sent in and some of the earlier comments, you are very familiar with the different types of fibroid, those on the cavity and those on the wall and so on. So the concern was, okay, well, does this medication only help certain kind of fibroid? So we looked at the results based on the location of the fibroid. And the good news, all different kinds of fibroid responded very favorably. We published this in the Gray Journal last year as well. So now I'm just going to show you kind of a high-level data from the Organoids trial. This also will appear in the New England Journal in the next couple of weeks. So here, very similar data. So here again, the timeline and the amount of menstrual blood loss. And again, the placebo group, unfortunately, continued to bleed heavily, while the group treated with Organoids combination therapy enjoyed dramatic decrease in their bleeding immediately in the first cycle. So this, one of the good things about this family of medication, they work very quickly. And again, as long as you stay on the medication, your bleeding will be under control. You bleed very heavily, very minimally. And on average, the decrease in menstrual blood loss was about 84%. And then finally, linzagolix. This is just one slide about some of the data. And linzagolix has the advantage of being available in 2 doses. And as you can see here in the high dose, 200 milligram with the add-back therapy, most of the patients, more than 93% of the participants enjoyed a major reduction in their menstrual blood loss and met the primary endpoint of the study. So how about adverse events, side effects? Generally, these medication was very well tolerated, no serious side effects. Now, I mentioned that when you cut down the estrogen level, you might have some of the side effects of hot flashes, night sweats, and headache. There was some of that, just slightly above the placebo, but certainly much less than when these medications are used alone. So when you add the add-back therapy, the little bit of estrogen and progesterone that I mentioned earlier, the risk of these side effects become very little. So this is my last slide, and this is kind of a summary of what the message I want to come across is, like anything in medicine, the way we teach our residents and fellows and students, any medication, any disease, you start with medical therapy first, with simple stuff. And then if the patient doesn't get better, if the patient fails, then you go to a more invasive treatment, whether it's procedure or surgery, etc. Not sure why fibroid seems to be upside down in that. So I hope we can make uterine fibroid a medical disease, again, a disease that you can help our patient by a simple prescription, something they can take in the comfort of their home and get relief from their symptoms. And here I kind of describe different scenarios. I probably won't go into for the sake of time, but I think this is a great option for women in the perimenopausal, women maybe in their mid to late 40s, when they have issues with the fibroid. But we know once they hit menopause, the change of life, like I said, once your ovaries stop producing estrogen and progesterone, the fibroid issue will be self-resolved. So I think medical therapy would be a great way to bridge women into menopause. Same thing for young patients, and I see a lot of those students, graduate students who are busy with their studies or their career, but they have issues with fibroid and they probably haven't even started their family yet. So obviously they don't want to hear the word hysterectomy or anything like that, or neither uterine fibroid embolization, in my opinion. So, so I think medical therapy is a great option to help them until they get their first pregnancy, because as I mentioned, pregnancy many times actually improve the profile of the disease. So after the pregnancy, in the postpartum period, many of these fibroid patients, their symptoms actually will not come back and will be much relieved. And even the group in the middle, maybe your patient had a couple of kids, maybe she even had a tubal ligation. I still would like to try medical therapy. The elagolix with add-back therapy is approved for up to 2 years. So for the first time, we have a long-term, reliable, effective, and safe treatment. I would like to do this and then evaluate after those 2 years and see if the patient actually needs any further treatment. Because again, the disease profile can change with time. So with that, I'll stop here and I'm happy to entertain questions either now or at the end of the panel discussion. Thank you.
Well, Dr. Al-Hindi, thank you so much for that presentation. And I want to thank you personally for not having a one-size-fits-all approach. I think that that is a detriment to patients when doctors just say, oh, here's the diagnosis, here's the treatment, be on your way. So I certainly appreciate your expertise and your patient advocacy as well. Now, a lot of people in our Q&A section are very interested in your slides regarding vitamin D. So I'm going to kind of give you a lump of those questions. One person is asking if women should ask their doctor for vitamin D blood test to see if that is a risk factor for fibroids. And then another person is asking how much vitamin D should someone take to get to therapeutic levels? Did you ever hear of vitamin D shrinking fibroids or getting rid of fibroids? And then what's the best way to up those vitamin D levels? Is it just hanging out in the sun or taking supplements?
Right. So the Endocrine Society actually has kind of a lot of guidance on this. So as far as measuring serum level of vitamin D in reproductive age women, that's actually a recommendation from the Endocrine Society already, aside from even the fibroid issue. So because this is a very common issue, so all women of color, all women who are contemplating pregnancy or in the childbearing years, basically all women, let's say from 12 to 52, that's actually, according to the Endocrine Society, it's a recommendation to measure their serum vitamin D levels on a regular basis. So I would encourage all our audience to talk to their healthcare provider and actually ask for that if they are in that group. Now, if you are diagnosed with vitamin D deficiency, which is again based on the Endocrine Society, level under 30 nanogram per ml, between 20 and 30 are considered insufficient, and less than 20 are considered deficient. But basically anything less than 30 is considered you don't have enough vitamin D in your body. Once you have this diagnosis, then again, the Endocrine Society have clear recommendation on how to fix that. Of course, the best thing is to talk to your healthcare provider, but what I do in my practice, I use 50,000 units per week for 12 weeks and then test again. And in many patients, especially women of color, that's not enough. So many times I have to repeat it for another 12 weeks. But the best thing is to coordinate this with your healthcare provider. And finally, about if this has been effective against fibroid, like I said, I haven't been able to do a well-designed, randomized, placebo-controlled study. I'm seeking funding now to do this. Hopefully we'll be able to do it. But I mentioned 2 studies from other countries who have done that and showed some encouraging results.
Okay, and just one more question for you. This is regarding the EGCG. Does that work for all different kinds of fibroids? Do you need more EGCG for larger fibroids?
Well, in our study that we have done, and we have done that actually in Nashville, when I was working in Nashville at Meharry Medical College, we did not exclude any specific diet. We included those in the cavity, those on the wall, and the subserosal, those bulging to the outside. And so based on that, I would say, based on that study, I would say, it should work on every kind of fibroid. We did not do a dose, size, response, and so on.
All right, Dr. Al-Hindi, again, you have a lot of questions directed your way in the Q&A section right now. You can respond to those directly, and we'll try to get to more of them once all the panelists have spoken. But I do want to keep us on time right now. Dr. Tabia Akintobi is up next, talking about the importance of community engagement. Dr. Akintobi, you have been in the Q&A responding to people already, so go ahead and direct your questions to her and take it away.
Well, thank you so much, and I just so appreciate the opportunity for us to engage with patients and communities to do what is so important, and that is to really be a bridge between the science, the translation of it, helping women to know their options, and having them really thoughtfully think about the so what for them, and now what in terms of why their voices are so important as those who might be suffering with fibroids.
Dr. Akintobi, this is Adriana. I'm going to stop you really quickly because something happened to your audio. It was totally fine before. It's a little jarbled right now. So I want to make sure that we disconnect you, reconnect you, and bring your audio back clean so that we can all clearly understand the important information you have to offer. So our administrator will get with you right now. In the meantime, Tanika Gray Valbrand is here. She's with the White Dress Project. Tanika, I know that you've been listening to the doctors speak and you've heard their passion for patient advocacy and making sure that patients have all the knowledge of the treatments that are available before they just do a one-size-fits-all approach. So Tanika, take it away.
Thank you so much, Adriana, for the introduction. And again, thank you to our partner, Morehouse School of Medicine, for hosting this important discussion tonight. And thank you to all of you for joining us tonight. Being here tonight, you have chosen to get more education as a clinician, as a student, as a patient. And that really is the first step in being a strong advocate. So kudos to all of you for taking the time to be here tonight. I'm Tanika Gray Valbrand, founder and chief patient advocate of the White Dress Project for Uterine Fibroid. We are based here in Atlanta, Georgia, along with Morehouse School of Medicine. And I would just briefly like to share with you why there is so much power in our voice as patients, power in our voice as physicians, as students, as researchers, as scientists. Tonight, we've heard from all of our well-versed doctors and researchers, a lot of clinical information, a lot of science and mechanics of uterine fibroids. And while I am not a doctor, I'm here to share with you the importance of becoming your own best health advocate and really seeing the physicians, like the ones who have spoken here today, as real partners on your journey. Here's a tip really quickly that when I started to think about how I become my best health advocate, I had to change my mindset. That was the first thing. I had to categorize all of the health practitioners in my life as my personal medical board of directors. They are here to advise me and offer, best practices, guidance, methods towards my symptoms and relief, and really help me along my healing. However, I did realize a few years ago, after having 2 myomectomies, suffering with fibroids since I've been about 14 years old, heavy menstrual bleeding, always, the protruding belly, always having to go to the bathroom, never being able to wear white, I knew that no one knows my body better than I do. And I truly had to become a champion for myself and my health. That meant not always taking the first opinion that I was given by a doctor as my final option. It also meant researching doctors and science on my own and speaking to others about their own personal experiences. And I love that Dr. Akintobi started with the quote from the chat, because it is so important that we share these stories. And whomever said that in the chat, you're absolutely right, that we're not sharing often enough. It also meant that listening to my body was going to be important. And this one is probably one of those that is the most important, because your body never lies. And if you learn the things that are bothering you with your body and the indicators that your body is giving you, then you can learn a lot. So who are we? We are the White Dress Project. We are a nonprofit organization. We're a patient advocacy organization. And we are really dedicated to raising global awareness about uterine fibroids. As someone mentioned before, we're not talking about this a lot. So it's our mission to make sure that patients have a voice so that we can spread education, research, community, and advocacy. As a nonprofit organization primarily made up of women with impactful fibroid journeys, we are uniquely positioned to educate, empower, and support those who are managing life with fibroids. Our work is actualized through our vibrant community, our connection to clinical researchers, our advisory council of health practitioners, and leaders in the field. But the most important part of our work is our patient community. Our patient community is our North Star and guiding force as we work to create an environment where their health concerns are believed, all their options are accessible, and where community research, advocacy, and science intersect. You know, when I think about why people don't feel comfortable talking about fibroids, you know, I often think about the barriers. And often when you have fibroids, you hardly feel comfortable wearing white, hence the name, the White Dress Project. Because many of the women who have extreme heavy menstrual bleeding, bloating, and urinary incontinence, it's a problem, right? So we don't feel comfortable wearing white. So we have used wearing white clothing as a symbol of hope that we will find a cure for uterine fibroids. And our goal is to continue to support the community we've created by improving patients' education of the disease state, quality of life, and working toward investigating research gaps. Now, obviously, there are some other factors that you know, get in the way of why we're not sharing our stories. But the statistics are staggering. 80% of Black women by the age of 50 will have some type of symptomatic fibroid. And research shows that the burden of uterine fibroids has a disproportionate impact on Black women. Although this disease disproportionately affects Black women, we understand very little about what causes this disparity. And while the doctors and researchers and clinicians tonight have shared a wealth of information, there's still a lot that needs to be researched and discussed about why fibroids form and also why Black women are disproportionately affected. In my opinion, fibroids should be considered a public health issue given the magnitude of the problem and the cost of healthcare for this disease. So some other things that why you know, people decide not to share or their barriers to their care and speaking up. There's fear, mistrust of the medical community, racism and discrimination, lack of information about the condition. And I think somebody alluded to that in the chat. There's also what we call medical gaslighting. And medical gaslighting is when a healthcare provider makes you question your sanity. And if you've ever felt that, please put that in the chat because it's such an important thing to recognize. You start to feel like the pain is all in your head, you're being hysterical, that the pain is normal, you should just take a Tylenol and Advil and keep it moving, and that's not true. In terms of our education programs and what we like to do at the White Dress Project, encourage patients to share their stories all the time through various programs that we have. So taboo talks and tea and talks and dialogue with the doctors. And all of these programs are just here to encourage patients to know that if we don't share, then no one understands what we're going through. If we're just taking PTO days and you know, not going to social events, no one understands our true burden. So why are our stories so important? James Seegers, who is the director of the Division of Reproductive Science and Women's Health Research at Johns Hopkins Medicine, said that fibroids are a bit like snowflakes. So snowflakes is the same, or are not the same, and no one cause for uterine fibroids is exactly the same, or I should say no one case of uterine fibroids is exactly the same. So that's why it's so important that we share our varying stories because there's so many variations in how fibroids can show up in a woman. As such, the decision about which fibroid treatment to pursue can be complicated. Ideally, treatment should be personalized to the patient's symptoms and priorities. So here's where you come in. Your voice and your story matters. And if you hear nothing else tonight outside of everything that the doctors have said, obviously, please hear me that your voice and your story matters. And you have to know that sharing your story is the key to living your best life and showing up in the world at your best. At the White Dress Project, we believe the patient voice is key. So even on this panel discussion tonight, I want to introduce one of our patient advocates. She is the Director of Advocacy at the White Dress Project, Amber English Coleman, and she's just going to quickly share with you her personal journey and why the patient voice is so vital.
Thank you, Tanika, and thank you to all the physicians on the call tonight, and thank you for everyone who's joined us. I have been a part of the White Dress Project family since 2017, but my fibroid journey began a little bit more than 10 years ago. I experienced a lot of what Dr. Lippman talked about. He talked about people hearing that their symptoms were normal. And like Tanika said, you know your body best, but it's difficult when you're sitting in a physician's office, you're sitting in somebody's office whom you believe to have all of the answers, right? The people that you are going to for help, and they are telling you that what you're experiencing is normal. So while it's important to know that you know your body best, I also want to hold space for the fact that it's difficult to push back on the people that we are taught and told are really supposed to help us navigate our conditions. And that, to me, is why it's so important to have patients speak up, right? You know, we speak up for one another. We speak up for the people who are just starting on their fibroid journey, who have just been diagnosed all the time at the White Dress Project. Our social media community is thriving, and almost daily we hear from people who have just been diagnosed. They think something might not be right. And it's important to be able to hear from other people who have gone on their journeys. It's also important to have the patient voice in the policy space, our advocacy work, which is near and dear to my heart. And the reality is your story is the most powerful tool when we talk about pushing for the policy solutions, and they do exist, to the uterine fibroid crisis. Those solutions are in the form of research funding and greater public awareness, but also practical things. We talked about how often people take time off. Uterine fibroids can very much be connected to the family leave issue, right? So there are a number of areas where our stories are very important in the policy landscape. And the final area, which is not uncommon for tonight, where we're in a room full of physicians, and I would position out there that it's really, really important for the patient story to be central with kind of recentering physicians on why they're doing the work. I'm so grateful to hear about all the research that is happening on different treatments, on different interventions. But the reality is, when we talk kind of scientifically and almost sterilely about symptoms that people are experiencing or deficiencies that people have, you know, there's a real life consequence. When you talk about quality of life, Q of L, the patient voice is the voice that can just practically break down what that means. When you talk about bleeding and using multiple pads, the patient voice is the one that's talking about, you know, I don't go out at certain times of the month with my friends. The patient voice is the person who can say, you know, that means I'm taking time off of work, and it's time off of work that I don't have. And that recenters why folks do what they do. And that's across any occupation. So I would just encourage anybody who is on this call who is a patient who's not sure what's happening, maybe to check in with the White Dress Project, share your story. because really our stories are our power. Your story is powerful for your own healing, but it's also helpful for helping someone else on their own journey to healing. So I'll toss it to Tanika.
Absolutely. Thank you so much, Amber. And I just thought it was so important to hear from another patient. Like I said, the White Dress Project is made up of patient advocates who are not just in this work, but we have our own personal stories and can really connect and relate with so many people who are suffering with fibroids. 10 years ago, there were no fibroid patient advocacy organizations. And women, really didn't have a lot of places to turn for support. But with groups like ours, we are changing and really raising awareness of the disease and amplifying patient voices. The last thing I'll say is that during Fibroid Awareness Month in July, Vice President-elect Kamala Harris and Representative Yvette Clarke introduced the Uterine Fibroid Research and Education Act. And this is to expand federal research efforts and bring much needed attention to this overlooked disease. And the patient perspective and the patient voice are really what is going to change the narrative around fibroid research, advocacy, and funding. As I close, I understand that sharing can be difficult, like Amber just alluded to. We want to make it seem like we have it all together. But in order to fully be advocates for ourselves, informing legislators, policymakers, the men in our lives, our family, friends, they need to hear our stories. Our life really depends on it. And the last few slides that we had there talked about just women sharing their stories and their vulnerability and just being open and honest. So I just encourage everyone who is in that position to connect with the White Dress Project. We are here to serve you and support you along your journey. Thank you so much for the opportunity.
Tanika, thank you so much. And you and Amber, you mentioned the White Dress Project being a family. It certainly is. It's one thing to get a diagnosis and be alone and suffer in silence and not know the questions to ask and not know that what you're going through is completely normal. And it's another thing to have that support and know that whatever journey you're on, someone can empathize and relate to you. So that to me is what the White Dress Project has done. I just know I was so alone and so devastated with my diagnosis, and come to find out I'm nowhere near alone. So I certainly encourage everyone to reach out to the White Dress Project. Okay, Dr. Akintobi, let's get an audio check from you, ma'am.
Can you hear me?
We got you, girl. Take it away.
So I'm going to jump right in because I want to be sure that we have sufficient time for all of the great questions that have come in. And I think this all worked out well because we've heard from just about the entire spectrum of what really brings us together in the work of Morehouse School of Medicine and this important partnership in all of the things that we do to train, to address primary care issues, to address the health of those that are disproportionately affected by health issues, with fibroids being no exception. We are here to lead the creation and advancement of health equity. And for us, that really is imbibed in what CDC says and what we really own as the definition of health equity. And you know that that term has been thrown around very loosely these days, but health equity for us means giving people what they need in the amount that they need it so that they have all of the facts that can allow them to live their best life and to achieve their most full potential. And I think the example of what we've embodied and hopefully provided and invited you an opportunity to join us in is what we intend to do. Give women all of the options, give them the best science, and give them an opportunity to have a safe space to ask and get answers to very tough questions. And as someone who also has suffered with fibroids, this is very professional and certainly very personal for me as well. So where all of this has come from in terms of Dr. Thompson and our initial engagement in the space of really elevating community voice has been through the Prevention Research Center at Morehouse School of Medicine. And loosely, we look at risk reduction and early detection, right? And so this certainly applies in the discussions that we're having today, particularly for African American and other minority communities. And we know women, particularly those affected by fibroids, happen to be African American. And as a gender, we have another layer of minority status that makes elevating our voices all the more important. And so the group that was among the first, beyond the Hill, as this research unfolded through this partnership, was the Prevention Research Center Community Coalition Board that Dr. Thompson alluded to. It is designed not to be a yes group. It has community majority in terms of governance. And so when this study was presented to them a couple of years ago, Dr. Thompson can remember it was not a silent room, because just about every woman and man there were affected or affected by a woman that was living with fibroids, whether it was their mother, a significant other, or someone that they knew. So the science here certainly meets women in a very important place and makes it that much more important for the science to matter. So I want to remind all of us the reason why this partnership is so important. And this picture is really important as well, because it includes the then former City Council President Cesar Mitchell representing policy. It includes members of our community and our president, Dr. Rice, and myself, science, policy, and community. And Ms. Trammell, who's in the middle of the five of us, always reminded us, and I think this forum reminds us, research is wonderful, but what do you do with the research in terms of empowering communities once you get it? And this collaboration is one example of that. So we must be innovative. We must think outside of the box in response to that question that I read by someone who said, women don't know that they have a problem. They think the problem is normal. But once we give them the science, we need to arm them with what they can do next, not just so that their voices are elevated so they can make decisions for themselves, but also that they can elevate their voices through opportunities and collaborations like the White Dress Project. So when we think about the TX concept briefly, we know that we are interested in making sure researchers like myself who deal in the community and social behavioral space are connected to folks like Dr. Thompson, who are in the basic science space. And certainly when we think about the work that Dr. Littman does, and also that Dr. Al-Hindi does, that patient-centered research connects. And frequently, we don't collaborate and partner even in the way that we're doing now. And less frequently do we engage intentionally groups like the White Dress Project that can do what we can't, and that is to advocate for policy, and that is to be influencers who really can get the word out and bring the word from communities on how we can engage them better towards better treatments, and also making sure that the disparities in terms of what's happening in terms of women with fibroids, that needle is shifted in the right direction. So very briefly, and we'll share this in the chat and after this panel, the TX concept was coined by Morehouse School of Medicine to equally prioritize a number of important elements that frequently are missed when we think about research. Oftentimes when we think about translational research, we think we're doing something wonderful when people like Dr. Thompson, myself, and Dr. Al-Hindi collaborate. That's considered innovative. I know that is not enough. We agree that is not enough. Our research should engage communities at every step so they can challenge the degree to which the research is getting out there. And as you all think about even your questions, there's probably a lot that you've heard this evening that you were not aware of before. And as that person who had that question and comment in the chat, it is our fault. We must do a better job of democratizing, that means leveling the access of this information in ways that are not just limited to great publications, which we have to do that too, but we must have these forums that bring together clinicians, researchers with communities to not only talk, but to also listen and collaborate as equal partners. So TX means that the community is engaged from the beginning, that we have interdisciplinary teams. So that means that the teams don't just include researchers. So the White Dress project as an important collaborator is also an important way that we can get out of the academy and make sure that people who should care and do care are engaged in the conversations. TX also means that research results broaden the evidence base. So you've heard from Dr. Al-Hindi, Dr. Littman, and Dr. Thompson. We want to be able to make sure that the science speaks and is evidence-based in terms of what works and doesn't. Most importantly, you all, the TX model of Morehouse School of Medicine requires that the results are adopted or adapted in communities. That means that what we learn has to change something. It cannot sit in our academic walls. It cannot sit at conferences. While all of those things are important to us getting funding, it must move out to where the people are. And it can't move there unless we come to you and collaborate to learn where you are, what questions you have, so that that trust can be built and solutions can be developed. So this is just another way to show it. TX, you can see here, Dr. Thompson represents the basic or biomedical science leadership. Dr. Al-Hindi in the clinical research space, and others like Dr. Lippman talking about one important option, and then myself in the work of the Prevention Research Center and community engagement. That really is that bridge between academics and researchers. Most importantly here, that adoption and adaptation in communities is through groups like Tanika, the White Dress Project, getting advocacy, policy, and action happening. It takes all of this to move the needle. None of it is less important than the other, but when we bring that together, it represents TX, and that's that exponential movement of research to community transformation. So I think it worked out well. We have closed the loop, and certainly this is the first in many discussions that we will have. So I'll turn it back over to you, Ms. Hopkins.
Dr. Akintobi, I'm so glad we got your audio fixed so we could hear that presentation. There are some questions for you in the Q&A, so I'm going to try to get to as many as I can before we run out of time. I also want to open the floor to some other questions as well. One question is, one barrier to getting research to patient care is the block that occurs with pharmaceutical companies who have not traditionally been interested in women's health. So how can we push drug companies to be interested in fibroid treatments?
Wonderful. I think it's really about one of the tenets of TX that I included there, and that is having interdisciplinary teams. So I'm very clear that industry should be a partner, that we're not only trying to engage when we have a product that's ready to go to market, but anyone, whether it's policymakers or pharmaceutical companies, they should be a part of the discussions along with communities and researchers in the very beginning, so that we can strategize together about how the messages can get out and there can be equal and bi-directional benefit for pharmaceutical companies as well as community residents and patients. The benefit has to be democratized as well for it to be meaningful, but I certainly would look forward to what Dr. Thompson and others might say on that as well.
Last question for you, Dr. Akintobi. Are you encouraged by our new administration, specifically Vice President-elect Kamala Harris? She has taken an interest in women's health issues, fibroids. There's a omnibus bill kind of waiting in limbo that addresses women's health issues and the Black maternal health disparity and mortality rate disparity. Are you encouraged by the next 4 years?
Absolutely, and I'm sure you could have predicted my answer. We are at an exciting time in our country where representative champions in women's health, I think, will have their day in ways that we haven't before. And I'll just leave you with this last part of the response. When we can separate politics from policy, the work of advancing research that matters for fibroids will happen. And I think the space that we're in with our vice president is an important indication that better is to come. And so hopefully these conversations and this collaboration will be a part of that.
Doctor, thank you so much. Okay, so we only have a couple of minutes left, and I do want to open the floor to some broader questions that we got in our question and answer section. One question that's been kind of an ongoing question all night long is about diet. What's the best diet for treating fibroids, reducing the size of fibroids? Should people be eliminating meat, soy, sugar? What's your take on this? Any doctor or panelist can answer.
I'll jump in. While we don't know where fibroids come from, they grow with estrogen and hormones. So that's why they grow rapidly during pregnancy and why they tend not to be an issue for women in menopause. So we take kind of an anti-estrogenic approach, and that can be a number of ways. One is try to avoid the hormone offenders, the estrogen-rich foods, if you will, which do include red meat, non-organic chicken, dairy. We also encourage increasing colored fruits and vegetables because they have flavonoids in them that block estrogen production. They block an enzyme that's important in estrogen production. We encourage exercise and weight loss because estrogen is stored in fat. And it's one of the reasons why African Americans disproportionately suffer with fibroids over other racial groups. In general, they have more body fat. And so while we can't pick our parents, there's a genetic component. We all can try to be as close to our ideal body weight as we can. So through exercise and diet, making healthy eating choices, more colored fruits and vegetables. You can also use dark chocolate and red wine, and try to avoid the hormone offenders. You can really improve your fibroid symptoms significantly. And so, yes, I don't think there's a particular diet. Oh, also vitamin D, obviously, check your vitamin D as we heard earlier. That's really important because only 10% of African Americans have adequate vitamin D levels. And so that's an easy one to check and to make sure that you supplement if needed.
All I heard was dark chocolate and wine.
Those have flavonoids just like colored fruits and vegetables. I kind of snuck that one in there. I don't know.
Wonderful. I appreciate that. Dr. Alahindi, did you have anything you wanted to add?
Well, I've been answering questions like crazy in the chat. So, but no, I agree. This is a good recipe. I'm not sure about the wine though. Although the red wine, I have to say, or the red grapes in general has this material. It's called resveratrol, which has been shown to actually help against fibroid. Dr. Greg Chrisman, when he was at the University of Michigan, published on that. But maybe you can take it from the grapes. I don't know. That's your choice. But no, I think Dr. Libman summarized it very well.
I do want to ask all of the panelists, in terms of, we have some people in the Q&A who say that they've been told this by one doctor and that by another doctor. How many second opinions, third opinions, fourth opinions do you recommend getting? And then how do you advise your patients to kind of pare down that information and tailor it to, what suits them?
So I can comment and then others please chime in. So I think this is absolutely right. And I see this all the time. I'm at a tertiary care center. So you can imagine I get patients after they have seen several other doctors. I think the work that, Tanika is doing, the white dress and the National Fibroid Foundation and so on is very important because I think really, and what Dr. Akintobi talked about patient-centered care, I think that this is the era that the patient really needs to know a lot about their disease, and many of them do. And I love that when the patient comes with printout from, Wikipedia and other sources, especially from trusted medical sources, because that makes my job much easier. But I think there is some responsibility on the patient to know because, for example, these new treatment options that I mentioned, there is some resistance, and there's more like a cultural shift, if you wish. The gynecologists in general are surgeons by training. They tend to do surgery. I would say they love to do surgery. Dr. Libman maybe can attest to that as well. So the patient needs to know also her options and say, what about this treatment option? I heard about it or I read something about it. And then I think gradually we'll see this shift. I'm a big believer that the patient should be offered all the treatment options, and we really should be working just like as counselor, and then the patient choose the best choice for her own. She's the one who knows her scenario, her goals the best, and we should just really help her find that option, and then of course execute that option after that.
Yeah, I would agree. I would, be your own advocate, as was mentioned earlier, is really important. You know your body better than we do. And if a woman goes to her physician and she's not happy with the answers she's getting, or if she's being dismissed, you leave. You find someone else that is understanding and is willing to take the time to listen to you and help you. It's not a paternalistic relationship like it may have been many years ago. I'm the doctor, you're the patient, do as I say. It's a team. We're working together to try to improve your health, and you're the driver of this, and we're the team trying to help you.
So one thing I would like to say for the patient advocates that are out there's an old proverb that says prevention is better than cure. So if we can get more funding from NIH, if you can advocate for that, then we can start addressing some of the root cause of fibroid. We can start to just tease out what caused fibroids to occur. We can have better precision medicine approach in addressing this question so that we don't have to go to the late stage of surgery, but we now know the mechanism of how these cells are mutated, how these cells may proliferate, how they respond to various hormones. We have a better, because that's basic science is what drive innovation. And through basic science is why we know that how steroid hormones function through basic science. So we need to advocate more basic.
I would really like to emphasize that, and the concept of prevention of fibroid is a relatively recent concept. We started to advocate this with collaboration with Dr. Thompson and others a few years ago, because to prevent a disease, you need to know the risk factor. You cannot prevent disease in the 150 million women in our country. You need to find those who have very high risk. And also you need to have something to prevent with. I mean, it's not enough to find those who have high risk and tell them, oh, well, you have high risk of this disease, and just let them live in anxiety without helping them. So with the data that we and others generated on vitamin D and green tea extracts, some simple intervention that's inexpensive and simple and has really no minimal side effects, the concept of prevention start to be a viable option. And I would really love to explore this, because I agree, prevention is such a common disease, an expensive disease. Prevention is the way to go.
And I definitely think, Dr. Thompson, that you're right in terms of advocating for yourself, and there needs to be more funding put toward women's health issues. And I think, we have seen this year with this election how important voting is, and knowing the issues and knowing where your representatives stand on issues, because that's another way that you advocate. You go and you vote and you say, you are saying things that affect my life directly, my health, my money, my children, and this is what I think is important, and you put those people in office and they work for you. Okay, almost out of time, so we have one more question, and I'll just ask for a brief response to this, and I'm kind of merging questions here. But what happens if a fibroid is just left in a woman's body without any surgery, perhaps against a doctor's recommendation to remove it?
Yeah, actually there was a question about that, and I think I answered, but in general, yeah, that's fine if the fibroid, and about actually 30 to 40% of fibroid patients are asymptomatic. They find that by chance when they do ultrasound for other reason, or they go and do a CT for a kidney stone and they find the fibroids and so on. If the fibroids are not causing symptoms, we don't need to do much about it. Because normally they would shrink once you hit menopause, the change of life, as most of us talked about. Now, if the fibroid doesn't shrink after fibroid, that should be looked at. That could be a potentially warning sign. So that definitely should be evaluated. But if the fibroid is not causing symptoms, there's no reason to do much about it.
All right, so I'm going to wrap up the Q&A section of our panel tonight. I do want to give each panelist about a minute to share some final words, whether it's advice for the people watching tonight, or just the one takeaway that you want people to get from your presentation. We'll start now with Dr. Thompson.
I would just like to thank everyone that have participated both on the panel as well as the audience, showcasing what we do best at Morehouse School of Medicine, leading the creation and advancement of health equity. Our president was present. She delivered an effective message and direction for us this evening. And I'm just proud of everyone that participated on the panel, and the questions that were asked were very informative, very impactful.
Dr. Lippman.
Well, again, I appreciate the opportunity to participate in this great panel. I thought the discussion was outstanding. The one message I would leave, I guess, is if you're suffering with symptomatic fibroids, research all your options, because there are options like UFE that you may not hear from anyone else. And so again, be your own advocate. If you're not liking the answers you're getting, keep going until you find someone or some answer that fits whatever you're looking for. And as I say, every patient that is a surgical candidate should at least know about UFE to make their best choice for them based on their desires.
Dr. Al-Hindi.
Right, I just want to echo the same notion. I would like to congratulate the Morehouse School of Medicine on such a successful event. I really think I enjoyed working at Meharry Medical College a few years ago. I think the HBCU medical schools really do a marvelous job connecting to their local community and really work together to improve the health of their local community. I hope the University of Chicago and other major institutions do the same. We are in Southern Chicago, so definitely there's a huge need for anti-fibroid awareness and events like that. And from the patient side, I just want to echo what we all said earlier, that as a patient, you really advocate for yourself by knowing all your options from the media, from trustworthy medical sources, and then to have this important, meaningful discussion with your healthcare provider to find the best plan for yourself.
Dr. Akintobi.
This has been an amazing first step in what we will continue together in really elevating not just the conversation, but also the solution. So one thing that I think is important in terms of advancing progress in fibroids research and to decrease the suffering are three important elements. The science must demonstrate impact, so we need rigorous research. The other important element is advocacy, to be able to bring the science to action. And the third and most important are community and patients whose voices are heard, elevated, such that this moves beyond simply a discussion of problems, but solutions. So high touch, advocacy, and science must work together to move the needle. And patients and community residents on the phone, you are central to that. So this is just the beginning, and we look forward to the next conversation.
And Tanika and Amber.
Well, I just want to thank, again, Morehouse School of Medicine, Dr. Thompson, Dr. Akintobi, Dr. Lippman, Dr. Al-Hindi for giving us so much information tonight. It was a wealth of information. To the patients who are joining us tonight, I just want to say, become the CEO of your body. No one knows your body like you do. No one can tell you anything about your body that you don't already know, that you're not already experiencing. So it is in your best interest to become the CEO of your body. And as I mentioned in my talk, make sure that your health professionals are your medical board of directors. Look at it like they work for you, right? They are the people who have been placed in your life to offer guidance and advice. Use that. Don't be scared to get a second opinion, a third opinion, a fourth opinion. Gather all that information and make the best choice for yourself based on the outcomes that you want for your life. Please reach out to us at the White Dress Project. We are here to support you.
I would just add that we are at a critical time right now for policy advocacy, and we need you. We have a great opportunity on our hands with the Uterine Fibroids Research and Education Act, but there's also so much more that we can do. So bring your stories with us to the halls of your state legislatures and the federal legislature, even in a virtual context. And I would just add that I got my start in Georgia and under the Gold Dome. And one of my favorite days was seeing all the doctors down there. So please don't believe that we don't need y'all to talk to these legislators. Please come with us, and whatever we can do as the White Dress Project to help you and help everybody become an advocate at that level, we're ready to do it. So let's rock.
Well, thank you everyone for joining us tonight. This was such an amazing and wonderful discussion. I'm always very appreciative when doctors and physicians and researchers and scientists are so willing to share the work that they're doing. And really, it gives us hope. And tonight, I'm just so touched by the doctors who have listened to their patients and made women feel not crazy. You don't know what that means to someone who is going through something that they don't understand. And we're looking to you for guidance. So I greatly appreciate all the panelists for participating tonight. Dr. Thompson, thank you so much. And please pass my thanks along and gratitude along to Dr. Rice for inviting me to moderate this amazing event. I want to let everybody know who was watching tonight, in the Q&A section, if you open that up and you go to the answer tab, you can see all of the questions there and all of the answers the doctors have given. There are currently almost 120 questions. So as you can imagine, we could not get to all of those live tonight, but they are there in your Q&A section. Also, if you go to the chat section, then you'll be able to find all of the social media handles for all of the panelists tonight. I encourage you to follow them on social media. There's nothing better than free information that doesn't have to go through your insurance company that you're not paying a copay for. So definitely go to their social media handles and click follow, keep up with them. Looking forward to more educational programs in the future. In the year of 2021, we certainly need some good news, some news of hope on the horizon for women's health. Thank you so much for allowing me to moderate this event. Thank you all for joining us tonight. We certainly appreciate it. And with that, you all have a wonderful night. Have a great week. Take some time to decompress from the news. And until next time, take care.